My patient is S.A. She is 30 years old female. She is teacher by occupation and resident of Iraq. History is given by interpreter and herself. Date of admission and date of examination on the same day, that is 1st of April on 2023. Chief complaint, she is P3L3 and she has been delivery by lower segment cesarean section on 17th of March 2023 in Iraq, and she presented to us on postpartum day 15 with chief complaint of bleeding per vaginum since last 10 days and pain abdomen since last 10 days. History of presenting complaint. I start my history from her present pregnancy, that is the third pregnancy. The pregnancy is a spontaneous conception, and she is booked case, and she was following regular antenatal clinic visit in Iraq. As per the patient, there is no abnormality detected till 36 weeks of gestation, and all the reports and the scans done were normal, within normal limit as per patient, but there is no details of document at presentation. She was apparently well till 36 weeks of gestation, where she was found to have high blood pressure on a regular antenatal visit. Though there is no medication was prescribed to her for her high blood pressure record, and she does not remember any evaluation for protein in the urine or any renal function test done that time. Following this, she didn't have any history of swelling of limbs or reduced urine output or breathlessness. No history of headache, blurring of vision, abdominal pain, vomiting. No history of loss of consciousness, abnormal movements of the body, and weakness of limbs. No history of yellowish discoloration of eyes, change in color of urine or stool, or itching of body. No history of joint pain, rash, and photosensitivity. There is no history of abdominal pain or bleeding or leaking per vaginum, and fetal movement was perceived normally as per her. With this complaint, she was electively chosen for lower segment cesarean section on 17th of March 2023 at 30 weeks of gestation, and she delivered a female baby of 2.8 kg who has cried at birth, and she apparently healthy and didn't require prolonged hospital stay. She has intrapartum and postpartum period was uneventful, and she had minimal vaginal bleeding at the time of discharge, which is on third day of postpartum day. She was apparently well for 3-4 days, and POD 6, postpartum day 6, she again developed increased bleeding per vaginum, which is started initially with spotting of few spotting, and gradually increased to along with the passage of clot while bleeding. The bleeding was associated with abdominal pain, which is mostly in the lower abdomen, continuous, severe in intensity, and leading to thigh. And this was associated with multiple episodes of vomiting. There is history of fever, which is continuous, high grade, along with chills. That time, there is no history of discharge or bleeding from the stitch line. She gives history of painkiller intake. She does not remember the nature of the painkiller. With this same complaint, she was admitted to the hospital in Iraq on POD postpartum day 7, and she was told to have she was having raised creatinine of which she remembers at 8 mg per deciliter. No history of reduced urine output or swelling of limbs or breathlessness that time. In view of raised creatinine, she was initiated on hemodialysis, and she received 2 sessions of hemodialysis in Iraq. She also received 2-unit blood transfusion in view of low hemoglobin, and she was also had that time she had recorded high blood pressure and started on antihypertensive medication. She came to us with the persistent symptoms on POD 15, and on evaluation she was found to have deranged renal function, though she was maintaining urine output approximately 1 liter per day. At admission she found to have high blood pressure record, and for evaluation of bleeding, ultrasound abdomen was done, which shows retained, which she told there was product of conception was retained, and there is a huge collection of blood. For that she was required to undergo surgery. So she underwent exploratory laparotomy on the same day, that is 1st of April 2023. After that, her bleeding stopped, and her clinical condition gradually improved, and her fever and bleeding subsided. She continued to remain dialysis dependent, and in stable condition she was discharged on POD. After 5-6 days of hospital stay, she was discharged on POD 20.
We'll hold on from here now. Now can you summarize, and I'll ask every one of you to what do you think is happening to this patient? Okay, can you just summarize it briefly about this patient? You have a summary? Yes, just go to, or do you have investigations or something? At this level, what do you think is happening?
I have summary. Should I put it? I have summary also.
Of this, no?
Yeah.
No investigations are in there?
No. Just after history. Summary, she is 30 years old lady with the previous 2 uncomplicated pregnancy, and she presented on after 3rd pregnancy, and 3rd pregnancy was uneventful till 36 weeks of gestation, and when she was detected to have high blood pressure, and she underwent elective lower segment cesarean section on 38 week of gestation in hospital in Iraq, and on postpartum day 6 she developed bleeding. She presented with postpartum hemorrhage, and that time she was found to have.
Do you call this postpartum hemorrhage? How do you define postpartum hemorrhage? Is there a time frame of post? Can you have postpartum hemorrhage after 6 days of delivery? Anyone? What's the definition of postpartum hemorrhage?
6
what is
weeks.
antepartum hemorrhage and what is postpartum hemorrhage?
Antepartum hemorrhage is before the delivery of the baby, placenta.
From what to what time? Any day, 2 days before delivery, 4 days before delivery? What is antepartum hemorrhage? Comes from what period of pregnancy to delivery? What period?
It can be.
There is a time frame, fixed time frame for this. Similarly, what is postpartum?
Postpartum.
What is peripartum and what is postpartum?
Postpartum can be present up to 6 weeks of.
Peripartum? These are all defined terms. No? Antepartum is 20 weeks to delivery. Peripartum, some period, and postpartum to something. But do you call this postpartum hemorrhage? Or will it be a right term, or is it bleeding parvojana? Isn't it? What are the causes of postpartum hemorrhage? The moment you use this word, you tell us about certain underlying diet. What are the commonest causes of postpartum hemorrhage? 2 common causes of postpartum hemorrhage.
Like one is embryo placenta, and
that is antepartum as well as postpartum. Is it the next one?
And then there is could be
abruption, and the second one?
And also uncontracted atonic uterus.
Yes, those are what? Placenta previa.
Placenta previa.
But do you think your patient has any of these problems? So when you want to go into a diagnosis of, you have to tell the examiner what is your thought process. The moment you use certain words postpartum, immediately, we are not gynecologists, but we will immediately think of atonic uterus, this the kind of, and placenta previa and all. I don't think your patient has any of those things, is it? Use a word. Postpartum, after delivery, had vaginal bleeding, day 6, isn't it? And that was associated with fever and chills and rigors and abdominal pain. So she underwent retained products and for continuous bleeding, isn't it? We have to come to this, but after that we have not gone into this other things. Now, any one of you, do you want to ask her some questions? For the history, for the diagnosis, what do you think you want to know more about this? What is your thought process? One of you, anyone can volunteer. What do you think is happening with this patient? That they have given history of fever, chills, vaginal bleed, retained products, everything has been given.
Hypotension during that episode.
She was
hypertensive, but blood at that point when she
Can you just think something when you have a retained products, we are bleeding, and you have developed severe AKI. How do you link both of them? Huh? Sepsis is one of them. So have you got any history for sepsis? Tell me. Do you think your patient who has retained products, who is bleeding, has developed severe AKI? How do you link this? Do you think this patient had sepsis? Is there any history about sepsis in this?
She has fever with.
Fever is not a diagnosis of sepsis, no? How do you define sepsis?
Sepsis is like patient who has systemic inflammatory signs and
One
when
sec-
presumed to be have infectious
What is
origin.
the American College of Chest Physicians diagnosis of sepsis, which is including? What are the criteria in sepsis? One, focus of infection.
Focus of infection and
Second,
SIRS.
investigation suggestive or
Of
diagnostic of
infection.
infection, a culture or whatever. And
Mhm.
third, evidence of.
Evidence,
Systemic.
systemic inflammatory response.
And how do you define systemic? What are the parameters clinically?
Yes, ma'am. There are 4 parameters, and out of 2 should be present,
Yes. What are the
like fever or hypothermia, raised TLC or low TL.
clinically we are asking?
Okay.
If somebody they wanted to know, your patient has developed acute kidney injury. We believe it is acute because antenatally
She had
doesn't
no.
have any.
Yes.
isn't it? And ask some of them will go just have to do what are the other things? One is hypertension, second is tachycardia.
Tachycardia.
So did you have the clinical evidence in the? Did you mention that? Because you have to tell us why this patient has developed. The first question is this patient has developed AKI.
Yes.
Second question is this patient is dialysis dependent AKI. So we have to define both of this to reach your. We are only looking at nephrology to reach your diagnosis. Biopsy at 41 days, fine, but that's another question. Should we have biopsied earlier, or should we have looked at other evidence as to why this patient is dialysis dependent? That we will go into it.
Mhm.
So sepsis. And the second one, what do you think can link a patient who has got obviously infection, retained products, fever, bleeding, and this kind of severity of infection? Anyone? DIC.
DIC.
So did you take any evidence of DIC in this patient? What are the clinical parameters that we should have looked for? You just said vaginal bleeding. You didn't tell anywhere else there were any bleeding.
Bleeding. Yes, ma'am.
That history has to be. You have
Okay.
developed somebody who's had an uneventful third pregnancy, delivered everything, except for hypertension in the last trimester, isn't it? And then suddenly you have a patient who's developed AKI and who's dialysis dependent. So something from the AKI we have to find out more. So that history, so we have not got DIC. They ask for why are you asking for DIC? Why is it important? Retained products, DIC, then what can happen in such a situation? Okay. Retained products, DIC and dialysis dependence. You know, cortical necrosis can present like this. And that tells you that the patient has developed a DIC. So the biopsy will be something else. So that thought process is very important. How severe was the insult and how bad it impacted the kidneys. So this is the 2 things you have to get. Now, I will ask you, if this patient has AKI, you have a creatinine 8. What makes you think that this is AKI? How do you make a diagnosis of AKI in this patient? A creatinine 8.
There is no previous history of
Previous history?
renal dysfunction.
How do you diagnose AKI? What are the parameters that you need for AKI?
One is urine output and also
Is the urine output is not issue second?
and the other is creatinine.
What is the current, criteria that you use? for-
Akin criteria.
No. Is the Akin criteria that we use nowadays or something else?
KDIGO.
What is the fallacy between Akin and KDIGO? I mean, what is the problem with, what does Akin say? What is the creatinine criteria for Akin?
Akin is 0.3 increase
In the last
in the last 48 hours.
48 hours. See, today you have 1. Tomorrow is 1.2. Okay? Day after tomorrow is 1.2. Is it okay? Next 4th day is 1.3. 0.3.
Mm.
Okay.
Mm.
The next 4 days is 1.4.
Mm.
Isn't this AKI? Because, but with your Akim criteria, it is not.
Not.
Because every 48 hours you have not risen more than 0.3.
0.3.
You understand? So you can have creatinine go up from 1 to even 1.8 in 15 days. But in every 48-hour interval, you have not shown any, let's say 0.3 rise. Is it? So how does KDIGO correct this? This fallacy? How is it? What is the KDIGO say of rise in creatinine? What is the time frame for KDIGO?
Presumed to be 7 days.
7 days. So this patient who was 1 creatinine and day 4 is 1.4 is actually AKI. Because within the last 7 days, you have
Rise.
risen by 0.3.
0.3.
So these are the differences. So if you, let's say you don't have a creatinine, okay, value for this patient. So how do you measure a baseline creatinine in this kind of a patient? What is the criteria that you take to say that this patient, this lady 30 years, would have had, because she is asymptomatic, a baseline creatinine of, do you know how do you measure that? She has come with 8 and you don't have any creatinine. But you say it's AKI, which you believe it's AKI, because there is no clinical finding. But to diagnose AKI, you use a baseline creatinine.
Baseline.
So how does KDIGO tell you to calculate a baseline creatinine in a patient of AKI whose outpatient creatinine you don't have? Are you aware of all this? So everybody will ask you for KDIGO, but they will ask you all these things. In your clinical practice, somebody comes in your ICU with 1.8 creatinine and you make a diagnosis of AKI the first day itself, but you don't have a baseline creatinine. So how do you make it one baseline? Is there anybody? Somebody will find this and keep it and let me know. Anyone? How do you look at baseline creatinine, or how do you presume what is the baseline creatinine in a patient whose baseline creatinine is not known and who's developed AKI? Well, then it's all there in KDIGO. It's there in the guidelines. What is the creatinine you will choose? For this lady, is it 1? For a 70-year-old lady, gentleman, will it be 1.4? What criteria that you use? You have to use, and which formula they use? Have you read? No. Find this out. It's there very clearly in the KDIGO diagnosis of AKI. So this patient, you are saying there is no evidence of acute kidney injury. I say there is evidence of chronic kidney disease. How do you say it is not there? I mean, historically, why do you think there is no chronic kidney disease?
Chronic kidney disease patient, because the patient has hypertension mostly at the hypertension she developed in the later half of the pregnancy.
So in chronic kidney disease, what happens to the hypertension?
They normally develop before 20 weeks of
That is
gestation.
pregnancy induced and chronic kidney. But what exactly happens to the hypertension in a person who's got chronic kidney disease in the first 20 weeks?
The presentation will be earlier and
No, not that way. If your patient comes at first 3 months and the blood pressure is normal, can you say that this patient has no hypertension before? Can you say there is no CKD? Why? They are saying no. Why? Because the blood pressure drops in the first trimester. So you cannot make a diagnosis of chronic kidney disease just by saying that the patient was hypertensive in the first trimester or before 20 weeks. That doesn't hold. But this patient was normotensive till 36 weeks. So that we accept. Don't say that just because the hypertension was not detected earlier, I mean, this patient was late, so it's not chronic kidney disease. So that fallacy does not accept. We didn't have any investigation. So 36 weeks of hypertension, what does it mean to you? How will you, that hypertension which we did not discuss at all, what exactly, that hypertension has to be more elaborated. You said it happened on 36 weeks. When did she get delivered?
she delivered on 38 weeks.
So 2 weeks we had. So
We
in that
had,
2 weeks, what happened to the hypertension?
she was
Improved, increased,
No,
decreased,
she was
antihypertensive?
not on any antihypertensive prescribed during the delivery, and there is no
No, not delivery. from 36
6
to
to
38
38
weeks.
weeks, she was not given any.
That blood
She
pressure,
was not.
any idea what was the blood pressure at that time?
She doesn't even know. Like she
But
was
they
told
said it was blood pressure.
Blood pressure.
There was
high
no
blood
edema
pressure.
at that time?
No, no.
And proteinuria was not checked. The
No.
only history I got from your DA that 36 weeks of hypertension. How do you define preeclampsia?
New onset hypertension after 20 weeks should be confirmed on 2 readings 4 hours apart, and there should be another preeclampsia defining event. It could be either proteinuria or other thing. Like
What are the other parameters?
other parameters like renal dysfunction, creatinine more than 1.1.
Those
or-
history we don't have. Clinically, any parameters which can be which are called as preeclampsia defining.
Pulmonary edema.
Is it pulmonary edema or what are the parameters?
She doesn't have any breathlessness
No,
or.
no, no. There are classical preeclampsia defining 1, 2, 3 the gynae. So
Eclampsia.
you have used some of them, but not all of them. Eclampsia is what? Eclampsia is preeclampsia with seizures, convulsions. So that is an entirely clinical diagnosis. If I say this patient has preeclampsia, why do you say it's no? Is proteinuria required for diagnosis of it? It's not required. So you have hypertension after 20 weeks, but do you have any other parameter to say it's preeclampsia? Why is it important that we want a diagnosis of preeclampsia in this patient?
Preeclampsia increase the changes the maternal and the perinatal.
That is all. We are not talking about this patient. How does a diagnosis of preeclampsia important for your future management?
Once the patient is having diagnosis of preeclampsia, there are.
What are the other risk factors of which you think, if you say, see, and why I'm asking you is this: you have a patient with postpartum AKI, severe AKI, not resolved. There are only few 3-4 diagnoses which can happen like that. One is already said by cortical necrosis. What is the other postpartum AKI which does not resolve? What is that other form of HUS, TMA. So, is the history of preeclampsia important in a patient with HUS, TMA? Is there a link between them?
Yes.
So, should we not take that history now? Because it changes your diagnosis. If you have a history of preeclampsia, there are risks of developing HUS, TMA much higher. Is that right? This lady has seizures after some time. That's another area. So she could have had TMA and then she developed a seizure. Of course, you did not do anything for the patient, so it shows that there was no TMA. Isn't it? Your investigations would have picked up TMA if you wanted to. Because you did not do. What would you have done if you had developed TMA in this patient? What would you have done? What are the other interventions you would have done besides dialysis in this patient?
If the patient
Plasma exchange and something else if you had the opportunity to eculizumab and the newer drugs. So none of these you did. So it's clear that this patient did not have TMA in your history. But it's important. If we have a history, you have to tell us. Your thought process should be so that you should give me, by the end of your history, I should have an idea what's happening to your patient. And that's how you will tell us. So this patient, we are not sure whether there was an eclampsia. And even that, when the patient came to you, you still did not elaborate how much was the hypertension and did you, what antihypertensives. She came to you post of day 7 or 8, no? When did she come to you? Post of day 15, I think. What happened to her hypertension? Now we have a clinical present. What happened to her hypertension?
When she was diagnosed with hypertension at the presentation, she had BP of 150/90.
150/90. Medicines given?
Yes.
Control?
Control.
Did you do proteinuria?
Proteinuria.
How much was the proteinuria?
Around 2 grams.
Is it important to know the proteinuria in such a thing? What are the fallacies of doing proteinuria, let's say post of day 15 of pregnancy? I mean postpartum?
When there will be blood loss, so.
Lochia. Lochia itself will, and she had a surgery and retained products and lot of issues. So that's fine. And proteinuria, whatever was pre-pregnancy, usually resolves by 6 weeks.
6 weeks.
So we should not make any comment on that. You understand? But what else would you have done with this patient when she came to you with presentation with hypertension and AKI? Which none of you do, most of you don't do. Which gives you a lot of information. What? Fundus examination.
I did.
You did? So what was the fundus
It
examination?
was normal.
Normal means what?
And there was no.
Fundus normal worries me, isn't it?
Yes, Mr.
That's
There
all.
is no arterial constriction or hypertension changes.
What are the earliest hypertension? We are not looking at malignant hypertension form. But what do you think, what were the earliest hypertensive changes she should have on?
Ma'am, there will be arteriolar pallor and there can be AV nicking.
Anything was there for her?
No.
So then you mean to say this is a recent onset hypertension. And if it's recent onset, then that means happened last trimester of pregnancy. So whatever disease she had is not because, I mean, that's what you're telling us. So you have to thought process is, this disease started at the last trimester of the pregnancy, was, let's say, pregnancy induced hypertension or preeclampsia, whatever word you want to use, went into develop renal failure. The retained products are just an incidental thing. Do you want to say that, make us say that? Do you think that is possible in this history? Because you had hypertension, recent, very recent onset, had in pregnancy. So now the ball is wide open. It could be any disease which can happen. Do you think that that's your thought process? You tell us, what are your differential diagnoses with this history?
Ma'am, I thought that's what happened to her first.
We all know what happened. Now you tell us what you think.
I thought it's preeclampsia, underlying preeclampsia.
First is the syndromic diagnosis. All of you should try to put it in a box of syndrome. That helps a lot. So it's acute kidney injury. Next is the forms of E. Yours is acute kidney injury, preeclampsia. Will anybody, how many of you will agree to this? Points in favor, points. Bolo. If anybody who disagrees in this, how common is AKI in preeclampsia? And that too, dialysis dependent AKI.
It's not very common.
It's very uncommon.
Very uncommon.
And it resolves with the delivery of the
Delivery of
child.
that.
So that's first diagnosis, which I think you have to now. It's a diagnosis of preeclampsia. Is a diagnosis that it will settle down. It will not. There will be no evidence of any kidney involvement. That's the classical teaching for 6 weeks. But now the belief is there are damage which continues forever.
6 months.
Is it not 6 months?
And even ever.
Years, lifelong, isn't it? And how commonly you biopsy preeclampsia patients?
Very less.
Is any indication that anybody biopsies preeclampsia? Hardly. And if it is preeclampsia, if you had any evidence or any other investigations, would you have done to sort of justify your diagnosis?
We could have done like some markers of preeclampsia.
What are they called? What are the markers called?
S-plates by
What is S-split?
S-plate is FM.
S-split 1.
S-plate 1 is a soluble FM like tyrosine kinase 1
And the other
and placental growth factor ratio.
how does it behave?
And these are
Is it the ratio is S-split by PLGF or PLGF by S-split?
S-plate by P.
So how do they behave?
And they have like ratio should be more than 38 to diagnose preeclampsia, predicted preeclampsia. But it has a negative predictive value more than the positive predictive value.
If it is high, doesn't mean anything. If it is less,
Let's
it almost excludes preeclampsia. Chalo, the next diagnosis, preeclampsia, we are a little doubtful because why after next one?
I like to keep acute ATN.
ATN and AKI are the same thing. In fact, you should use the word ATI. Why ATN or ATI acute? AKI, ATN, why? But then acute tubular necrosis is again a pathological diagnosis. We always are looking at clinical diagnosis. Then you come and talk to us pathology when you have biopsy or something like that. Okay. And this patient is AKI or AKD?
Ma'am, it's AKD.
That's the first thing you should now make in your final diagnosis.
More than 1 month.
Is it more than 1 month or 14 days or what is it? Huh?
More than 7 days and lasting less than 3 months.
You understand? So the first thing that you have to, when you say AKI, till this time, but at the clinical presentation in your final diagnosis, this is AKD. At least now AKD, isn't it? So pre-eclampsia we have known the history, and the next one you say AKD ATN ठीक है. Why ATN? What is it in the history that tells you there is an ATN? In place of ATN, I will think of cortical necrosis. It's the same thing, no? Cortical necrosis is what? Is a spectrum of severity of the tubular damage goes into a complete cortical necrosis. Isn't it? So if you think, we will think of cortical necrosis because its dialysis dependent. Anything else? Why not postpartum HUS?
Yes, ma'am. I have kept like post thrombotic microangiopathy, postpartum HUS.
At the end of the day, to keep your examiners in the way, you should see that you have just not fixed one diagnosis. The moment you have finished your taking presentation, immediately form a short summary and then take your differentials and then say plus and minus. Okay. So TK, we have now, you said postpartum, TMA, and third one was anything else? Anybody else? Anybody else? Acute interstitial nephritis or anything? Passing urine.
Passing
Isn't
urine,
it?
yes, ma'am.
And
She
God knows what medicines
multiple,
she's taken there and all those things.
antibiotics and
Antibiotics, what medicine, Iraq में क्या दे रहे हैं उनको.
Yes, ma'am.
So never miss that diagnosis. Rare AIN after withdrawal of all medicine, but then there have been multiple insults to this patient. So this diagnosis you should always, first is this, then comes the pathological compartments you should think. Which part of the kidney is more important? Interstitium or glomerular or the vascular compartment? You understand? And then formulate your diagnosis. Finally, of course, pathology is later. Now, investigations, what investigations you ask, she will tell you. What's your CBC hemoglobin?
CBC was
It's clinically, chalo, let's see the clinical history. Anything you have to give us in the clinical history that is important?
actually she was discharged. After that she again presented
And then came with GTCS.
GTCS.
And the GTCS?
Was GTCS was further evaluated, though that time she was having controlled blood pressure. So with first diagnosis was pre-eclampsia, presenting as a complication of accelerated hypertension. But that time her blood pressure was controlled.
Eclampsia is not a complication of accelerated hypertension.
Like,
Eclampsia is a complication of pre-eclampsia. Period. It is not complication of anything else. You have to be very careful as you choose your word. Take your time. Nobody will stop you. Yeah? But don't say anything that the examiner jumps on. So GTCS, secondary to hypertension, some other thing. Now when you did monitored GTCS, what all did you look? Did you look for any metabolic parameters? For
yes,
the
like we have to second diagnosis for the seizures. I thought because of patient is having fever and ongoing sepsis, could be an embolic.
Embolic, septic, etc.
Septic encephalopathy.
But ongoing sepsis have come down, no?
Now she again actually presented with recurrence of fever and lower tract chest infection.
Sure infection?
Yes, ma'am. She has
You
culture.
say recurrence of fever and then let the whole team decide whether she has an autoimmune disease which we are missing. You understand? Don't give her, you have said recurrence of fever. You have given all the history. But why not lupus, postpartum lupus is exactly it can develop like this. Exactly it can behave like this. You understand? You may have just a small changes in the anemia, we cannot say anything because she has bled. Some little bit of thrombocytopenia here and there, some enzyme changes, and this is how it will present. This is a fever, you have treated properly, you have removed the source of infection, now she's come back with fever and GTCS. I'd say what prevents you from making a diagnosis of lupus nephritis? 36-year-old lady, isn't it? What percentage of lupus the first diagnosis happens after pregnancy? Anyone?
More common.
No, not that way. The first diagnosis of SLE by lupus following or during a pregnancy. A lady who's absolutely normal gets pregnant, develops some problems, and then you realize she is SLE. Similarly, today we were discussing what percentage of nephrotic syndrome is diagnosed on evaluation of a pulmonary embolism. You understand? So, patient is absolutely normal, comes to your hospital with pulmonary embolism, then you go back and work up and then realize this is a patient of untreated nephrotic syndrome. Same, this you have to all tell me. This is rheumatologist will tell you, it's not rare, but there is a de novo diagnosis of LN during a pregnancy. And it need not be the first pregnancy, it can be after 7-8 pregnancies also. Have you ever heard Dr. Liz Lightstone talk? You should. She is an authority on lupus and she has a slide on this also. I'll try to get it for you, but you all try to find this out. So it could be, the patient is absolutely normal, has gone through a pregnancy. When is lupus more common, diagnosis of lupus, antepartum or postpartum?
Postpartum is more common, and antepartum mostly they present with extrarenal manifestations.
You understand? It's very important. And LN diagnosis is more common postpartum. So you have given us a diagnosis of AKI or AKD, preeclampsia, a TMA, and we have put cortical necrosis, interstitial nephritis. Now we go on, what is the other CBC? So there is nothing else, no? In that history, nothing, no? Nothing that you want.
She has some cause of metabolic work. Also, she has prior thyroid surgery, which is done in 2008. Details of which is not known.
Toxicosis.
Yes, so it could be
a surgery with thyroid replacement.
Yes,
malignancy.
Ma'am, she was asymptomatic and she is requiring thyroid replacement of 150 microgram once a daily since like 2008.
Did you all evaluate this more?
Yes, ma'am.
No. Did you look into it with thyroid microsomal antibodies, वो सब कुछ किया था? Nothing.
She was that time she was having hypocalcemia. So
that can explain the seizures also. That's what we wanted to know. Whether an hypocalcemia was when?
Ma'am, she had hypocalcemia during the time of seizures. At the presentation also, and she was on replacement, could be because of the surgical removal of parathyroid during thyroid surgery.
So if you remove parathyroid, why should you? I don't think Iraq is so bad that पूरा parathyroid निकाल देंगे thyroid surgery. Do you think they should do that? No, nobody does that. Parathyroid gets spared during a thyroid surgery. So I don't think it's very simple for you. Don't speculate. Check your PTH in this patient.
Please check and it is low.
How low? No, that's answered.
It is 11.
Go back again. Let's go through it now. No. Okay. So no, we have done this. Go ahead. So nothing else in the history. Does this change your thought process? Somebody who's pregnant, who's developed hypertension during pregnancy, has got dialysis dependent, has a history of endocrine disorder. Does it change? Would you be thinking of something else in this patient? Autoimmune is one. So thyroid parathyroid abnormality causing gland being removed, autoimmune thyroiditis, yes, we can think of. Anything else? Sheehan's would have made her very hypotensive. Sheehan's is if she bleeds a lot. But we are thinking of what is happening in this history. Isn't it? She had a that's a pituitary necrosis secondary to hemorrhage. Anything else? Any other problem which can manifest during pregnancy? Any other endocrine disorder which can manifest as hypertension? Pheochromocytopenia. You can have multiple endocrine neoplasms. You remove the whole thyroid with parathyroid. must have been some papillary carcinoma of thyroid or whatever, God knows. And they can also be, but then she should have developed seizures during pregnancy itself. Was she on calcium supplementation throughout pregnancy?
She was on calcium supplementation throughout the pregnancy, but
And when you first checked, was her calcium alright?
no, ma'am. She was having low calcium only at presentation.
So that's another addition we have. So history wise, we have somebody who has undergone a thyroid surgery, okay, and the PTH is low. In a situation of low calcium, which is abnormal, isn't it? That's all. Now, anything else would you like to give us on the history?
My mother was
Next.
she
Any investigations you want from her besides the routine? Then next is after that. So we have given this LIC-ATN, this is her blood pressure. Go back, go back. Comparable left arm, what do you mean?
I mean, it was like
It's the same
almost
for left arm and
left arm, right.
no headache, no other history she has
No,
given.
no.
Next. Anna plus NT means present. यानी present लिखो. Minus NT तो नहीं होगा ना? Then what will it become? Uterus, sinus, not there. Present.
There is no thyroid swelling, but there is a midline heel scar to the neck.
Next.
Fundus examination is normal.
No.
And there is no rash or joint tenderness. Systemic
You
examination.
know what is this scar called? We could written present on the lower abdomen. 10 centimeters on the lower abdomen. Phalansteal. Right? Phalansteal scar present.
On inspection,
All this is fine.
fine.
Next one. Next.
Other system examination also normal, within normal limit.
So, LFT, what is your albumin?
Albumin is 3.2.
This is post-op day 50 in
15 at the presentation, ma'am. And Iraq,
the
she.
PCR doesn't matter much, 8.16. Did you repeat the PCR after that?
Yes, ma'am. It was 2 gram.
When was it?
Like after 10 days or something, maybe.
Before the biopsy, did you repeat it?
Yeah, it's almost like before the biopsy. It was same day, 2 gram.
Anybody comment on the LDH? You would say.
LDH
First, is it high or low or normal or abnormal?
it's a high one.
According to your laboratory.
Laboratory.
Yes. What does it mean for this patient?
Though LDH is high, there is no other evidence of hemolysis.
So what does
So,
LDH mean? What does lactate dehydrogenase stand for? These are basic questions. If the examiner wants, they can help you. What is this? What is an LDH? What is the role of lactate? What does lactate dehydrogenase do? Simple. It converts lactate to pyruvate, isn't it? No, not pyruvate. It is used in the anaerobic life cycle, converting from lactate to pyruvate and other whatever polycycle element. And what enzyme is this? This is a which are the body cells that has this? What cells have this enzyme?
RBCs.
RBCs next.
On the liver.
Liver, then
placenta also.
placenta, then muscles, brain. So many areas this happens. So what is the significance for your patient? You have to tell us. Is there any significance on this?
No, like in the pregnancy it is high only, so.
But she is not pregnant anymore.
Yeah.
So does it resolve? You have given a value. All the other we understand. This number you have given. If you tell us, you have to tell us. Does it help you in your diagnosis? Does it in any way?
Yeah, ma'am, we have to follow the.
So it can be a marker of hemolysis in your patient. No? You just have said RBC. Isn't it? said, no? And the hemolysis could be anything, drug induced, any other disease. Not really only you to have thrombocytopenia to make a. I will not ask that question. How many of TMAs need to have low platelets? Can you make a diagnosis of TMA with normal platelet counts? Yes, because I asked it's yes, but are you aware why is it like that and what situation you can have a normal platelet TMA? This is one more question you will know. Sometimes it's asked, in a diagnosis of TMA you need not have a normal, huh? Understand? So those are areas where you can have normal platelets. Understand? Next one. Yes, we have said this is vagina, all the cavity has been cleaned and all those things, isn't it? Retained products. Next.
Ultrasound was showing normal size kidneys.
Again the same question, can you have TMA without schistocytes? What are the parameters for diagnosis? Is it absolutely necessary to have schistocytes in your, and how many schistocytes you need in your peripheral smear to make a diagnosis of a angiopathic, microangiopathic hemolytic anemia? Are you aware schistocytes present both you? But have you asked your rheumatologist what is the significant number of schistocytes in a hypertrophy? 2 and more than 2 is considered to be significant. So you should write no schistocyte, okay? And creatinine is okay, this is fine. Albumin still, this is the same report, no? Next. This is a concern, calcium low, phosphorus high, IPTs. Yes. So what do you think is the metabolic diagnosis?
She hypothyroidism.
TSH is normal, no?
TSH is normal.
She's a thyroid replacement.
Replacement.
Yeah. Okay. Hypothyroidism on replacement.
Replacement.
Next.
And hypocalcemia, most likely due to
Isn't it hypoparathyroidism? What is preventing it from?
hypothyroidism.
Isn't it? Phosphorus may not be important, even in hypoparathyroidism, phosphorus go, but then she is AKI. So that is not fine. So where do you see basal ganglion calcification? In this kind of group of diseases?
Hypoparathyroidism.
So hypo. I will discuss later. Next, Guru. So she has hypothyroidism, hypoparathyroidism, which could be not a congenital one, it could be part of. When did the surgery happen in India?
In 2008.
How old was she at that time? 15 years, 21 years of age. No, she's 36 now, no?
Yeah, 30.
30. So 15 years of age. Next, Guru.
Then
before kidney biopsy, we don't go to kidney biopsy. So what do you think is now that you see, the next question is, this patient has not recovered renal function for 41 days.
41 days.
And you are dialyzing regularly.
Yes.
Urine output?
Urine output is maintained. She was maintained.
Non-oliguric?
Non-oliguric.
AKI.
Okay.
Isn't it? So what are the other investigations you would have done to find out why is this kidney not recovered?
She has undergone all the other DIC workup also.
Something else. I would have asked anyone from your side? Anyone? Easily available. Helps you in your diagnosis.
Complement level.
Complements, we can wait till 42 days. There are issues with complement levels in pregnancy. What happens to complements in pregnancy? The moment you ask, you get questions. Anyone, what happens to complements in pregnancy?
Complement levels are increased in
Complement levels are increased during pregnancy. So very difficult to diagnose hypocomplementemia in patients with pregnancy. And that may last up to 6 weeks. So that might not help you. But something else? Kidneys are not good.
ANA and
That we are not ANA. What happens to ANA in renal failure? The moment you ask these questions, we'll ask you. What happens to ANA in renal failure? Anyone? What is ANA negative glucose? What are the parameters where your ANA will be negative, but still you have you heard of it?
yes, ma'am.
Huh?
ANA can be negative and
In what types of-
drug induced
drug-induced and
yes, and
severe renal failure. Find out why that happens. Who will tell us why ANA becomes normal in not all patients? You know, when we were students, if you have lupus nephritis, whose ANA is negative or whatever, and you put them on dialysis, because dialysis is immunosuppressive. I mean, the kidney failure is itself is immunosuppressive. So they were not offered transplants. They were made to wait for 6 months to 1 year because your kidney function may improve, because you have given them uremia as a immunosuppressant. Understand? Similarly, renal failure is so immunosuppressive that you don't have any autoantibodies, so you don't pick up ANA. One of the parameters, but nowadays there are ways of which ANA is negative, ELISA or IF, which is easier, you can find out, but that is possible. So ANA is not going to help. If you want to get DSD, but something, leave the blood investigations. Anything else? CT. Plain CT itself. What will you see in CT abdomen in this case? What calcification? What they call?
cortical calcification.
How are they? Where do you see? Is there a sign? What is it called?
Rim sign.
Huh?
Rim sign.
Rim sign. So how do you see that? What happens? Define the rim sign.
But there is a rim of calcification
Right.
mostly because of the
Where,
capsule.
where? In the medulla, in the
Right.
capsules,
In the caps-
around
in the cortex.
Cortex.
In the cortex.
all completely surrounding.
Yes.
So you get cortical nephrocalcinosis, and that's called a rim sign, and that helps you in the diagnosis of.
Cortical necrosis.
So you could have looked at that.
Yes,
When what is the sensitivity of this? When does this sign becomes apparent?
It takes time to.
What? How much time?
3 months.
Even before that. Even before that. By 42 days, if you have a extensive by 6 weeks you can even find that out, because it could have precluded your biopsy. Did you do a CT scan?
Yes, ma'am.
What did
That are not showing any cortical necrosis.
What did the CT show? What do you look in a CT scan? What are you looking in that CT? If you want to find out about the diagnosis, what are the things that you will look into that CT?
Ma'am, we will look for the cortical uptake of the dye. If the
Are you giving dye or you have not given? You have given dye to this?
Yes, ma'am.
So what else would you look for the dye?
Ma'am,
Cortical uptake means what? What happens to the cortical uptake? See, you have done a contrast CT. There is a wealth of information in that. What else can you find?
we can look for avascular uptake less areas in the.
What was your CT? What did it show?
I didn't bring it down.
No, report card. So you don't. That's one thing. What the mind doesn't know, the eye doesn't see.
Ma'am,
It
it
is
is
what the
normal.
mind doesn't know, the eye doesn't see, and the doctor doesn't bring the report. Isn't it? Normal means what? What were the blood vessels? How did the blood vessels go? Huh? We could have got information for renal vein thrombosis. We could have got so many other information. Isn't it? Not just the cortical thickness. Even the cortical thickness, could you find out? What was the cortical thickness in that time?
Cortical thickness is normal.
What is normal cortical thickness?
More than 1 centimeter.
Is it the CT a good investigation, or what investigation gives you a better cortical thickness? If you are asked to look at cortical thickness, which investigation gives you a better idea of cortical thickness? Ultrasound or CT?
Ultrasound.
Did you do an ultrasound pre-biopsy?
Yes, ma'am.
What was the cortical thickness?
It was normal. The kidney size was around 2
Never say normal. You should say the number. What is the size means? If you are asked what is the blood pressure, you give the reading. Don't say normal. Same. You understand? Kidney size is 12 centimeters normal. What is the normal kidney size?
9 to 12 centimeters.
How do you say that this is a normal for an individual?
And there are graphs or nomograms.
Nomograms, if you don't have a nomogram, if you have a 2-year-old child who has a 6 centimeter kidney, how do you know it's normal? And a big man who's got a 12 centimeter kidney, how do you know it's normal? Nomograms तो बात है, इंडियन की तो nomograms ही नहीं है बात। हम लोग तो we keep on matching 8 centimeter चलता है normal है कर लो, 9 centimeter भी चलता है, isn't it? Anyone? These are all clinical questions. Size of the vertebra. Your own vertebra, the kidney size is how many vertebrae?
2.1.
So more than that, 3
2.5.
vertebrae. 2.5 to 3 vertebrae. So if you're a small child, measure 3. The lumbar vertebrae is not anything else. Measure the 3 of them, that should be your kidney size. You understand? And it's very important for children. And you can just take an X-ray, KUB, and then that itself gives you a kidney outline and you can find out. Isn't it? What is the issue of giving contrast CT in a patient who's got no GFR? So I'm surprised what information you actually get in a person whose kidneys are failing.
Actually, the CT was done for the seizure evaluation and
Of the brain or
brain.
the kidney? I don't think kidney will give you an information for the
No,
seizure.
CT contrast was done for the head, so
So that
in
the
that
whole pura kar diya
one.
tumne. From top to bottom.
Yeah.
Tell me, same question, if your creatinine is very high, what information you will get? Will you have any explanation of the dye? So how are you even going into the looking at the flush on the kidney or the nephrogram phase of the kidney? What happens to the nephrogram, you understand? No? When do you get the nephrogram in a normal CT scan? When do you look for, at what minute you look for the nephrogram?
Initially, there will be vascular phase.
So no, if you're asked, somebody asks you, you're looking for the nephrogram because you're looking at the vascularity, flush, areas of infarcts or whatever, isn't it? So you should know which cut on which time frame of the dye is it? Are you aware of this? And what will happen to a patient who's got no creatinine of 8? Have you ever thought of all this? So CT में did you look into, and the CT kidney was done. So what all did they say? I'm surprised what they looked. You could have got a lot of uterus all over the place. Uterus तो नहीं है. Uterus is there.
Uterus is like not in uterus. Uterus is there, but there is ligation of the bilateral.
ठीक है, that's tubal
externality.
ligation. You understand? So what was it? And in a let's say in a X-ray KUB, when do you look for nephrogram? What are delayed images? When do you look for them? And why do we look for them? The CT you have done not for the kidney size. You have done for the CT to let us know what is happening with the kidney. Why is it not recovering? So your thought process should be there. So if the kidney is not recovering, there must be something wrong in the pre-renal. What is the artery happening? What is the vein happening? Then in the kidney, is there any infarcts? Is there any cortical necrosis? Then finally, if there is an obstruction, if there is any, you have ligated both the ureters, for God knows. That is also possible, during your hysterectomy. So do you think a contrast CT will give any of this information? Have you ever seen a kidney which is non-functional? How much of the blood flow happens to the kidney? Have you seen a report of a contracted kidney in an ultrasound? Doppler done in a contracted kidney? तुमने कभी report देखा है उसमें से? If you ask somebody to do a Doppler in a kidney which is 7 centimeters or 8 centimeters, what exactly you get out of the blood flow in that?
The blood flows.
You cannot make out it's called power stardust pattern and you hardly see any blood flow. Same happens with CT. If you have a 8 creatinine, you're not going to get any image or any flash or any lighting of the kidney. So the contrast CT does not help you unless you're looking for vascular abnormalities like renal vein bhi nahi hai. There is no excretion. The dye is going in and then coming out is also there. Arterial thrombus, arterial occlusions, or a vascular catastrophe. Obstruction to nothing. No dye is going to come into the ureter because there is no GFR in this case. Is it?
Yeah.
So whenever you ask for an investigation, be very careful. Clinically, you have to justify. So your CT was normal. I don't think it would have been normal, no? Because you wouldn't have seen anything in the CT.
It's normal.
What are they written normal? You got the report? Huh?
Yeah.
Okay, just anybody, any one of you, how many of you have seen CTs in chronic renal failure or AKI? How many of you have seen dialysis dependent kidneys for CT? Have you ever seen any CT? How it looks like, images? Oh no. Cortical necrosis, yes. Because you will see no blood flow. What are the parameters of, you're not asking for that. ACN, so she will tell us. But that's what vascular, if you have ACN, there will be hardly any blood flow into the kidney. Isn't it? But do we need was the CT done for ACN or was it done for other diseases? So that's what she has to tell me. Why was the CT was done?
CT was done actually for the other thing also because she was presented again with sepsis, so we have to look for all this uterine sepsis, focus of sepsis also, and she has seizures also.
You have the report or we will go back to it later? What are the, now that you said, what are the vascular, what are the radiological findings of cortical necrosis? Do you need contrast or you can do it without contrast?
X-ray also.
No, you get a calcification. That you don't need, and you can find it in, as she says, in the X-ray also. You don't need contrast to get the rim sign. Rim sign is which one are you talking? Calcification. That's a rim sign. There is something called yellow sign. And you want, what is yellow sign? There are few different signs you have to know. One is calcification. The other is lack of blood flow into the kidney. That is what you can find out. What does it say? Okay, we'll find out, don't worry. Now tell us what is your biopsy and what were your thought process before your biopsy? Okay, I'll go through it. Give, but let me see what I wanted to look. Is it there? Mention. What were your thought process of the biopsy? Unresolved renal failure. Prompt nephrogram. उसके बाद they have not mentioned anything about the pelvic LEC. Ureters नहीं बताया. ठीक है, prompt nephrogram. Prompt तो नहीं होगा. Symmetrical. Symmetrical I accept that both kidneys are. So why did you do the biopsy? And what were your thought process for the biopsy?
Because patient was
What was your clinical diagnosis for the biopsy? Unresolved AKD?
AKD and suspecting cortical necrosis
Just suspecting anything else?
and
Glomerular disease thought
glomerular
process?
disease to rule out any other.
Abhi tak, was there any hematuria still in the
No.
last?
Well, eventually was there.
No, not this one. 41 day 41.
41 days was repeated and hematuria was persisting. Like she has 5 to 6 of RBCs, still a high quantity, and proteinuria also was 2 gram before the biopsy.
Did you do ANA, all those tests you have done? What's your biopsy?
Biopsy is showing of 13 glomeruli and 3 tuft was entrapped in an area of cortical scarring involving 10 to 15% of the sample cortex, and remaining glomerular tuft was normal, unremarkable. There is no mesangial expansion or mesangial cellularity or endothelial proliferation, no necrotizing lesions, and tubular interstitial compartment is showing mild interstitial inflammation is seen in the scarred cortex, and non-scarred cortex shows diffuse acute tubular injury of moderate degree. Vascular compartment was unremarkable.
There was your diagnosis? What is the histopathology of cortical necrosis? Huh? And what happens to the glomeruli? Completely coagulative necrosis. You will see blobs of, as he says, no cells, completely coagulative necrosis. It's a necrosed glomeruli. Vasculars will be also. So what is this? I mean, so they have given you a diagnosis. What do you think is your clinical diagnosis? There's nobody, no harm in making your diagnosis, no? You have to now tell the patient what is going to happen to this patient.
So, I think it's a preeclampsia.
You have got 10 to the 5% sample cortex is there, no?
18, and there is some cortical necrosis.
So if you have diffuse ATN and areas of cortical necrosis, what does your final diagnosis become? Is it diffuse ATN and areas of cortical necrosis or patchy cortical necrosis? It becomes patchy cortical necrosis. And what do you think caused the patchy cortical necrosis?
Patchy cortical necrosis are more common than the.
No. In your patient, what caused the? What was the disease process of anyone? I think it is the retained product and DIC, isn't it? I don't think it was the preeclampsia. Preeclampsia is still a red herring, isn't it? Where is the preeclampsia? No, I don't think okay. What is the biopsy findings of preeclampsia?
There will be endotheliosis.
What is endotheliosis?
Swelling of the endothelium.
And that, I know very little to say. Have you ever seen a biopsy series of preeclampsia? So it's very important very difficult. Go into your textbooks. Earlier days there used to be biopsies, hardly nobody does it. So it's very difficult to say whether the preeclampsia changes persist till this time, 42 weeks. So there is no evidence of preeclampsia in your biopsy now, but it is not easy to say that there is no evidence means it was not there. It might have been there, now it has resolved because the baby has died. So this is patchy cortical necrosis. That's one. Now, I mean, what caused this? What do you think? And as they say, it's just not a hypotension or blood loss. It is hypotension, blood loss along with the sepsis, retained products and DIC. And we had no evidence of, your history did not show any DIC except that raised LDH. Isn't it? You don't have your PT. You have to show us that, no? And FDPs. Anybody who has got your, see, I know it's difficult for us to do it, but I would ask a patient, if you want to make a diagnosis of DIC, what are the investigations? PT, APTT, fibrin degradation products have to be there for us to, and those three, how does those three help you in your diagnosis in postpartum care? If you have PT, APTT, deranged, normal then? What is the discriminatory value of PT, APTT and FDP in a patient like this? If it is normal, it more up to HUS and TMA. If it is, because you can have anemia, thrombocytopenia in DIC also. If it is abnormal, it fits in more with DIC. Again, if it is normal, it fits in with fatty liver and even HELP. Then it is normal. So it is very important to have your PT, APTT. If it is abnormal, it almost always puts you into the group of patients who have developed sepsis and DIC. And that is why there were multiple factors which leads to this kind of severe ATM. Now, how will you prognosticate this patient? What will you tell him?
And because the patient has 10-15% cortical necrosis, and most cases the diffuse ATM, so there is a chance of recovery and could be delayed.
Could be delayed, but how will you explain to, what would you tell him now to do? What are the parameters that you are looking into?
I'll ask her to monitor the urine. If she has.
She's monitoring her urine output. She's with you or she's gone back to your house? So you have to, how do you assess recovery in such a patient? How do you do in your clinical practice, what will you do?
Check for the
Urine output to ठीक है, so that is not going to change. And you are not looking for a polyuric phase of urine output in this kind of, because there is diffuse ATN and patchic cortical necrosis. So you may not even have that diuresing phase. So forget that. How will you check this patient? How do you tell your patients his kidneys are improving? क्या करते हो? Check your PhD creatinine, look into your weight gain, look at the urine output and all those things. And what else will you offer? Advise him.
You can monitor the blood pressure and you can look at the residual renal function.
These things you will do. Blood pressure, residual renal function, all these things are fine. Hello? Yeah. Can you call me after some time? I am with the class. Okay, ma'am. So, what else?
You can,
What will be your follow-up care for this patient?
you can
Correct antihypertensives, correct the hypocalcemia. Have you started vitamin D for this patient? Vitamin D, isn't it? No phosphate binders? What is the problem with phosphate binders with this patient? What kind of phosphate binders will you use? Calcium containing. Why? Why not available carbonate? The hypocalcemia also gets corrected. And what do you think is the kind of bone disease you expect in this patient? Adynamic. So, if you give calcium carbonate or as a phosphate binder, what will happen? What will happen? That we have to be. We are not looking at hypercalcemia happening because as it is, she is hypocalcemic. So that fear you have to explain to the patient. We are giving vitamin D. We are giving calcium. We would prefer calcium containing phosphate binders because it takes care of hypocalcemia. We would not prefer sevelamer and all because they have a very strong suppressive ability of PTH, whatever little is left. Not just through phosphate binding. PTH has other ways of suppressing your. Sevelamer has a pleiotropic effect in reducing your PTH indirect to the pathway of phosphorus. How does PTH come down? You bring down the phosphorus, PTH comes down. Isn't it? And sevelamer brings down the phosphorus, that's how we believe brings down the PTH. But then those are theory questions, but there are high phosphate, PTH reducing effect of sevelamer carbonate indirect, not with the pathway of just phosphate binding. There are intricate FGF23 pathways through which PTH comes down. So we don't want the PTH to come down more, the bone is very adynamic, isn't it? So as she says, we have to tell them about vascular transplant. And next, you have told her about nutrition, you have to guide her for AV fistula. Isn't it? You're 6 weeks with a catheter. That is the idea you have to tell if you. And how long will you wait for the kidney not to improve? We are already 6 weeks down. So by another 6 weeks she will be seeking it. Isn't it? Then you are not looking for much of a recovery. Then you have to think of AV fistula. The next question, would you offer transplant? Think very carefully and tell me, what will you do next time if you want to offer transplant?
I like to wait for another.
Why do you want to wait? So you wait, but how many years or how many months you want to wait? Would you offer her transplant? Up to she's 30 years old, isn't it?
We should offer her.
If you are given a choice to offer transplant, what are all investigations you will do before you offer a transplant? What is worrying all of us in this case? This was a lady who just came with some vaginal bleeding, had minimal sepsis, and went into cortical necrosis. Isn't it?
I should look for this
Apla. But that was PT-APDT was normal, but we should investigate completely for antiphospholipid syndrome. We should also have a basic autoimmune workup done before the transplant. Something else. This lady does not fit into your garden variety of. She didn't have massive postpartum hemorrhage. You just gave her some 2 units of blood, isn't it? And that was a vaginal bleeding. She had retained conceptus, but that was not like a florid DIZ bleeding from her nose, mouth, everywhere. No hypotension noted, isn't it? But then she's got into a diffuse ATN, unrecoverable and patchy cortical. You should ask for complement mutations in this patient. This is the underlying complement mutation is the first hit. A very simple single hit has created such a catastrophic. Preeclampsia does not cause AKI, recover. The baby is out, conceptus is out, AKI should recover. Isn't it? Hypertension is not so bad. That you should do. And also I want all of you to read, I also don't know, how does hypoparathyroidism, or for that matter endocrine abnormalities, modify the natural history of AKI? We all read the GPCS was because of hypocalcemia, part of AKI, CKD, hypopara, all those. But is there a link between? And you should always try to get this history. But malignancies is over, 15 years now. Nothing that you will prevent you from a transplant. Now she is 15 years now. Thyroid malignancy, what would you have been? I don't know. Medullary carcinoma of thyroid as a part of men. And there was no FEO and all those things. Adrenals were normal. Isn't it? Pituitary looked normal. Only basal ganglia calcification. Pancreas looked normal. So we have ticked all the major MENs. Isn't it? That's how you should. You should offer a transplant, but you should tell her you have to be careful about it. Analysis we have discussed, anemia you are taking care of. That's it. Anybody, any questions, anything? Every case discussion is actually clinical. Isn't it? The same question, baseline creatinine you have to know. Off the cuff, the creatinine baseline is the creatinine of that person, of that age and gender, whose MDRD GFR will be 70 ml per minute. You understand? You have to go backwards. You have a lady who is 30 years, who is a female, and whose age is 30, female, and the GFR should come as 70 ml. Then you calculate what is the creatinine. And that is the baseline creatinine in a person who is asymptomatic. These are all there. I mean, this is off the cuff. I think there is a fallacy with this for elderly people. You understand? And then 70 ml of GFR is quite common at the age of. So they may have a creatinine of 0.7, 0.8 or something, which will be baseline. And then even if it is 1, it should not be AK, but it will appear as if the patient has. These are the critiques of KT-GO definition where you are using baseline creatinine, rise in creatinine as a marker for questions I didn't ask, I don't think theoretically matters, is all those biomarkers in AKI, blah 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 blah. I think you are aware of biomarkers in AKI. That I think is asked very frequently too. Any other thing? I didn't even ask you what are the differential diagnoses of postpartum AKI. There, the commonest are all those preeclampsia, eclampsia, HELP, fatty liver of pregnancy, postpartum HUS, postpartum sepsis. So these are, and each one has a difference. What happens to the hemoglobin, what happens to the platelet, what happens to the LDH, what happens to the PTA, PTT, what happens to the liver functions. That's how you, and those things I think you all can make out. But it is important when you apply clinically. I was waiting for the PTA, PTT. You gave me just an LDH, isn't it? So PTA, PTT is normal. And this is a lady who could have had even some form of catastrophic apnea also. How did we? The biopsy did not show us anything. The vessels are not mentioned. Was there any vessels? There was no fibrinoid necrosis, anything? Thrombus in the vessels? Anything? I didn't get you all, no? If you can, you are from both from? Dharamshila, Narayan. I met you. Did you all get any prize on the poster? No. The next two? Huh? Kannaram. Dono I know. Both the eyes? All four?
Vedanta.
All four?
Three marks for it.
No, nice. Artemis. And there is some lady who she's not. Any questions? Did you learn anything today? But you have to all go back and get back with questions. I wanted you all to get some, क्या बोला तुम लोगों को? Endocrine and AKI. And what was the other one? The GFR one. Read properly. I'm just giving you off the cuff. You should read. What is the baseline creatinine? How do you calculate it? And what was the other thing you wanted to know? Tachycardical necrosis, radiological signs, and
Manage, prepare for transplant.
pregnancy treatment.